Hello everyone, welcome back to my YouTube channel Dr.Barki's Ophthalmology Tutorials. Today we will discuss about the congenital glaucoma. I will be discussing the congenital glaucomas or the childhood glaucomas under the headings of overview of this congenital glaucomas, classifications and how to examine these children with a glaucoma, what are the symptoms they present with usually and what are the differential diagnosis for these symptoms, and what are the signs exactly you should look for when you are evaluating a case of congenital glaucoma, and the treatment options available, especially the surgical options. Then I will be briefly explaining about the primary congenital glaucoma. Okay. So why you should know about this congenital glaucoma? Though they are rare cases, but they are really vision threatening and they pose a challenge when you are diagnosing a case and even the management of these cases. So in this congenital glaucoma, the children will have a raised IOP, okay, secondary to abnormality in the aqueous humor drainage system. So the abnormality can be congenital, that is there is a problem with the trabecular meshwork, or it can be associated with other ocular diseases or the systemic diseases. So you can define it as a group of diverse disorders in which there is abnormally high IOP due to developmental abnormalities or secondary to ocular or systemic abnormalities, which is giving rise to obstruction to the aqueous humor drainage. So children will have the glaucomatous changes, raised IOP, but the causes can be different. Okay. So coming to the classification, depending upon the causes, it is classified into primary congenital glaucomas and the secondary congenital glaucomas. Primary congenital glaucomas are usually genetic in origin. They are associated with aqueous humor outflow obstruction. Okay. Usually there is a membrane-like thing near the trabecular meshwork which is obstructing the aqueous humor outflow. Whereas in secondary congenital glaucomas, the outflow obstruction is usually secondary to either the ocular diseases or the systemic diseases. So usually these secondary glaucomas are caused by like trauma, okay, or there can be neoplasms of the eye, inflammations of the eye like uveitis. It can even be lens-induced glaucomas, steroid-induced glaucomas, etc. And there is one more entity called as pseudophakic glaucoma or the aphakic glaucoma, which are usually seen in children who undergo cataract surgery. Okay, the children who have congenital or the developmental cataract usually undergo the cataract surgery, and they may be left with IOL or without IOL. If they are with IOL and they may develop glaucoma called as pseudophakic glaucoma. If they are left aphakic and if they develop glaucoma, they are called as aphakic glaucoma. Here the cause is entirely different compared to your primary and secondary types. So this explains the etiological factors also. So in primary glaucoma, there is a membrane-like thing which is spread over the trabecular meshwork, thereby obstructing the outflow. Whereas in secondary glaucoma, the causes can be either in the eye or the systemic causes which are leading to glaucoma, and one more entity is pseudophakic or the aphakic glaucomas. Examining these children with congenital or the developmental glaucoma is a real challenge because most of the things have to be done very precisely, but here the children will not be cooperative. Little older children you can examine in the outpatient department only, whereas the younger children needs examination under anesthesia. Okay, so there should be proper examination under anesthesia. So what are the aims of examination? What you want to conclude at the end of your examination? You should either confirm or exclude the diagnosis, that is the presence of glaucoma. The second is to determine the cause for the glaucoma, whether it's primary or secondary to other etiological factors. And the third is gathering other informations like previous ocular surgery and other ocular findings, okay, which help in the further management of this patient. So these are the three aims of the examination of these children. So what are the symptoms these children present with? Usually the parents will notice the abnormalities in the eye or the behavior of the child, or even it can be a pediatrician who recognizes these changes and refer them to ophthalmologist. So what are the symptoms? Either the parents may tell that eyes are looking large, that is ophthalmos. The cornea can be, that's the black part, can be enlarged compared to the other children or the other eye, or even there can be whitish opacities which are seen in the black part, that is the cornea. So these can be the symptoms. Even the parents will present with symptoms of hyperlacrimation or the epiphora, and the child may have the symptoms of photophobia, like they will close their eyes whenever they are exposed to bright light, and even the patient can have blepharospasm. So these are the symptoms of these children. So the triad of congenital glaucoma is blepharospasm, photophobia and the lacrimation. You can remember it by the mnemonic BPL. So what are the causes for these symptoms? It is mainly because of the raised intraocular pressure. Whenever there is raised intraocular pressure, there will be stromal edema as well as the epithelial edema, which will lead to the corneal haze, which will be usually the first sign which parents notice. Okay, and secondarily there will be lacrimation, photophobia and the blepharospasm. And because of the continuous raised intraocular pressure, the eyeball goes on stretching. So the eyeball stretches leading to the big eyes or the ophthalmos. Okay, so the ophthalmos can be defined as the enlarged or the big eyes secondary to raised intraocular pressure. So it occurs up till 3 years of age. The cornea keeps on becoming bigger up till 3 years of age. Okay, so as the stretching continues, it also becomes thin and becomes more translucent and becomes bluish because of the enhanced visualization of the underlying uveal tissue. Then there can even be lens subluxation and rupture even with a minor trauma. Okay, so these are the pathophysiological changes which occur in congenital glaucoma cases. As I told, the examination of these children is a real challenge and it is very crucial when you are making a decision process. If the child is having central steady maintained fixation without any associated nystagmus, it indicates that child is having fairly good vision. Okay, then it is the right time or the high time you should intervene and treat the glaucoma at earliest. In external examination, one is look for associated abnormalities like neurofibromatosis or the facial hemangiomas. You can also make out some of the facial features of the metabolic abnormalities or the connective tissue disorders or the chromosomal abnormalities. Sometimes the external examination of the eyes can lead to the diagnosis of even the systemic disorders like in case of oculocerebral renal syndrome or the Lovis syndrome. Okay. One of the most important things in the examination of congenital glaucoma cases is the examination of cornea. When you are looking for a cornea, look for the enlargement of the cornea, edema of the cornea and the scarring of the cornea. Okay, so how we check the enlargement? By using the millimeter scale, or you can use the calipers when you are doing examination under anesthesia in OT. Okay. Because of the constant rise in intraocular pressure, there is enlargement of cornea up till 3 years of age. And because of the same reason, there is epithelial edema as well as the stromal edema. So once it starts healing, it may leave behind some scarring leading to corneal opacity. So whenever there is acute rise in intraocular pressure, it produces breaks in the Descemet's membrane called as haabs striae. Remember, the haabs striae are horizontal lines which are because of the breaks in Descemet's membrane. So there will be edema as the IOP comes under control. As the IOP reduces, it starts healing, but at the site of break, it leaves behind a scar called as haabs striae. Okay. We have one more striae in the cornea, that is vertical striae, which are seen following forceps delivery. Okay, remember haabs striae are horizontal HH. Okay, haabs striae are horizontal seen in congenital glaucoma. The opposite is vertical striae, which are seen following forceps delivery. The diameter of the cornea I have shown in the chart. Okay, so if the diameter of the cornea is exceeding the normal range, then it may give a clue for the possible diagnosis of the glaucoma. Examining the cornea, also look for associated abnormalities of some of the syndromes like Axenfeld-Rieger syndrome, where you see the posterior embryotoxin. Look also for the central corneal opacity as well as the adhesions between the cornea and the iris. When it comes to examination of the limbus, you can appreciate there will be stretching and thinning of the limbus with the deep anterior chamber. The measurement of intraocular pressure is the most important thing, and it really presents a challenge because in OPD the children will not be very cooperative and they start squeezing their eyes, which will give rise to false raised intraocular pressure. We are doing the OT by using anesthetic agents. It may also vary the intraocular pressure to some extent. The effects of anesthetic agents on intraocular pressure I have discussed in my video on intraocular pressure and tonometry. Please have a look. A calm child in a OPD is an ideal situation in which we will get the exact intraocular pressure. So what are the methods to check the intraocular pressure in children? It's best by using Perkins tonometer. Even you can use tono pen. Okay, as well as the eye care system of tonometry also gives equally efficient readings of intraocular pressure. Pneumotonometer is indicated whenever you are doing examination under anesthesia, whenever there is associated corneal opacity or the corneal scarring. But Schiot's tonometer is not recommended even in examination under anesthesia because it underestimates the intraocular pressure. So the normal intraocular pressure by age is shown in the table. So the IOP should be appropriate to that particular age. If it is more, then again goes in favor of glaucoma. The next important thing is the gonioscopy, which can be done in outpatient department or under general anesthesia. So how this trabecular meshwork in children differs from that of the adults. Trabecular meshwork in children appears as smooth homogeneous membrane which is extending from peripheral iris to almost bulbous line. Okay, it is not pigmented here. As the child becomes old, it becomes coarse and pigmentation appears. One more important examination, that is the examination of fundus. Here should look for three important things. That is, one is the disc evaluation proper. The second is the associated fundus abnormalities which help in making or confirming the diagnosis of glaucoma. Like in case of STAC, which is present in persistent fetal vasculature, there can be foveal hypoplasia in case of aniridia, or even there can be choroidal hemangiomas like in case of Sturge-Weber syndrome. The third important thing is to help in the surgical plan, like the child may need vitrectomy and the peripheral laser along with the glaucoma procedure if the child is having peripheral retinal pathology or the vitreous stranding. So at the end of your fundus examination, have a proper disc evaluation, look for the associated fundus abnormalities and also for your surgical plan. So how to do your fundus examination? It can be done with a slit lamp biomicroscopy using 78D or 90D lenses, or you can use indirect ophthalmoscope with 14 diopters of lens, which will give a better visualization of the disc. It can also be done using direct ophthalmoscope over your Koppe gonioscopy lenses. Okay, so these can be used even in undilated pupil. So when you are examining the optic nerve head changes in these children, the changes are almost similar to the adult optic nerve head changes seen in the glaucoma, which I have discussed in detail in optic nerve head examination. Please go through that video. So how these changes in children differ from that of the adult is, in children there is a scleral canal enlargement, that is horizontally there is scleral canal enlargement which causes further enlargement of the cup in addition to that is seen because of the actual neuroretinal rim loss. Okay, and the cupping proceeds very rapidly compared to the adults, and at the same time it is reversible if the IOP is controlled. This may be because of the incomplete development of the connective tissue of the lamina cribrosa. Though the cupping is reversed, the visual field changes or the loss which occurs is not reversible. Okay, please do remember this point. Though with the control of intraocular pressure, the cupping is reversed, the visual field changes are not reversible. And one more important thing that differs from that of the adult glaucoma is, in adults, if there is significant difference or the asymmetry of the cupping between two eyes, we consider it to be a glaucomatous changes. But in children, it may suggest glaucoma, but it is not confirmatory for the glaucoma. Okay, these are the points which are slightly different from that of the adult optic nerve head changes. I put this refraction at the end because the changes which give rise to refractive errors are because of all the changes which I explained now. So there is constant enlargement of the eye up till 3 to 10 years of age if the IOP is raised. Okay, remember the cornea keeps on enlarging up till 3 years of age, whereas the sclera still stretches for 3 to 10 years if the IOP is not controlled, giving rise to the myopic changes. So the children will usually have myopia. They may also have astigmatism which needs correction in addition to the treatment of glaucoma. Otherwise, child may have amblyopia because of refraction, though the IOP is controlled well. So other tests which help in the diagnosis and management of glaucoma is ultrasound, that is B scan to look for the axial length, central corneal thickness. So normally in 6 to 23 months of age, the central corneal thickness is 540 micrometers, whereas in older children it is 550 to 560 micrometers. And the cornea is very much thinned out in case of congenital glaucomas, but it is thick in case of aniridium, aphakia and aphakic glaucomas. Okay, but the correlation of the central corneal thickness to IOP as seen in adults is not so significant in children. Okay, and the fundus photos and OCT are helpful in follow-up and monitoring of the patient. In the management, though we have medical management and surgical management in case of adult glaucomas, the medical management has a limited role in case of childhood or the developmental glaucomas. Here the miotics which are used may paradoxically increase the intraocular pressure by collapse of the trabecular meshwork. These are the three mainstays of treatment: goniotomy, trabeculotomy and trabeculectomy. The main principle of this surgical management is you are incising and opening the trabecular meshwork, which is a site of obstruction in case of these congenital glaucomas, thereby helping in drainage of the aqueous humor. So how you can approach this trabecular meshwork? Either by internal way or by the external method. If you are entering the eye by side port and then incising the trabecular meshwork, that is called as goniotomy. By the external approach, like after conjunctival flap and the scleral flap, you are approaching the trabecular meshwork and incising it, then that becomes trabeculotomy. So in goniotomy, we are doing side port and introducing this goniotomy knife, okay, and then incising the trabecular meshwork. So this is done by using Coppe type of gonio lenses. Visualize the angles, introduce the goniotomy knife, and then incise and cut open the trabecular meshwork, thereby facilitating in the drainage of the aqueous humor. Though this procedure needs to be repeated several times, the ultimate success rate is up to 85%. So this is one more picture which is showing the goniotomy procedure. This is the Coppe gonio lenses with a goniotomy knife which is introduced, and this is the trabecular meshwork which they are incising and opening up. The next procedure is the trabeculotomy. Here from the external approach we are reaching the trabecular meshwork and incising it. Okay. So this is the haabs trabeculotomy which is used in the procedure of trabeculotomy. This inner prong goes in the trabecular meshwork area, whereas the outer one acts as a guide to locate where exactly the inner one is. So this is the procedure. Here the conjunctival flap is made, followed by the partial thickness scleral flap, and then a continuous delicate scratch is done over the Schlemm's canal till the aqueous humor comes out of this. Once the aqueous humor comes out, the outer prong of this haabs trabeculotomy is introduced through the canal, okay, and then the trabecular meshwork is broken by moving this arm into the anterior chamber. Similarly, the procedure is repeated on the other half by clearing the blockage in the drainage of the aqueous humor. The technique is highly demanding and requires previous experience and good anatomical landmark to achieve the predictable results. And the third procedure is the trabeculectomy, which is similar to that is done in case of adults. And most of the surgeons usually prefer combining the trabeculotomy with the trabeculectomy procedure, which gives better results compared to trabeculotomy alone. So your management doesn't end there. It needs a continuous follow-up of these children. Okay. So usually children are reviewed after 1 month for control of the IOP as well as the surgical stability of the eye. So in the follow-up, it is always important to measure the intraocular pressure along with the corneal diameter. Increase in the corneal diameter is almost analogous to the optic nerve head changes which are seen in adults. Means these are so diagnostic. If there is increased corneal diameter, it indicates that that glaucoma is progressive. Okay. And also do cycloplegic refraction whenever the child comes for follow-up, and look for the myopic changes and the astigmatic changes which occur, and give proper correction to overcome the amblyopia. And one more important advice which you should give for this congenital glaucoma patient is to protect from the trauma. So these eyes should be protected from trauma because they are more susceptible for traumatic changes like the subluxation or the dislocation of the lenses also. Coming to differential diagnosis of the symptoms of these children. Okay. So the cloudy cornea or the hazy cornea can be because of this congenital glaucoma. The differentials include the intrauterine rubella infection. There can be metabolic disorders like mucopolysaccharidosis or the mucolipidosis, or even there can be congenital hereditary endothelial dystrophies. These are the DDs for your cloudy cornea. The second is the large cornea. Here it's called as ophthalmus. The DDs include megalocornea, or very high myopia patients will also have large cornea. The third is the lacrimation, which is also seen in case of obstruction to the nasolacrimal duct. So these are the differential diagnosis for your most common symptoms of glaucoma. This is one of the questions which are frequently asked in your vivacity also. So whatever I spoke till now is common to all congenital glaucomas, okay, which may be primary or even maybe even secondary. So there are something which are very particular to primary congenital glaucoma. As I told, there is no other ocular or the systemic diseases which are associated in this primary congenital glaucoma. These are the gene location for the primary congenital glaucomas. And the classification of primary congenital glaucoma is like the true congenital glaucoma, okay, which accounts for 40% of these congenital glaucomas. Okay, here the intraocular pressure is elevated in intrauterine life only. In infantile glaucomas, which accounts for 55% of these congenital glaucoma, the glaucomatous changes manifest before third birthday of the child. Whereas in juvenile glaucoma, which is least common, the glaucoma changes appear between 3 to 16 years of age. Okay. So these are some specific points for primary congenital glaucoma. So hope this video on congenital glaucoma was helpful to you. If you find my videos are useful to you, please do subscribe to my channel. Press the bell icon for further notifications. Please do like and share my videos. Thank you so much.